So let's have questions, and let's keep the questions, because again, we're going to have general discussions, and then we're going to have specific panel discussions. So for the purposes of this discussion panel, let's keep them for the last two talks and related. I'm going to start off with a question, actually, because first of all, it was a great talk, both of them. It was interesting because the one patient, Jerry, that you showed with the Chiari and said how many people would let this young adult play contact sports. So we're talking football, right? Probably the most aggressive and physical contact sport there is. The second case you showed was, because I think I was the only one that said I wouldn't let him play. And I'm pretty conservative where I look at the whole thing and, you know, you got to put this person's life in perspective. That being said, the child with that syrinx, my take on that is that syrinx clearly wasn't caused by one header or even a couple headers, right? That was it looks like something a little bit more chronic. That's my kind of reasoning for not doing that, is because to me that was someone who had a Chiari, had a syrinx, did the header, which was kind of gas on a fire, and then now turned him into asymptomatic to symptomatic. And that's kind of the philosophy. But I'd like to take a poll, a real poll here, yes or no, not an answer for the faculty. That case that Jerry showed, or any case, a Chiari, significant Chiari, asymptomatic, would you let them play football? Football. How many who would? How many would not? Interesting, okay. And again, there's no right answer, but it's interesting. So, Dr. Keating, professor, I want to hear your...
Well, I live in a city with lots of lawyers,
which makes me even more complimentary of that.
It's all fair, but again, I think if you honestly believe you've addressed the problem adequately, you really feel that you've done whatever you need to do to fix the problem, then you have to go back to the etiology of the Chiari, and the patient's doing well, and you've got lots of room. I'm not aware of any studies anywhere or any reports anywhere that those patients are at any higher risk than you and I are.
Oh, two different things. So I think everybody would agree with that. Actually, in my talk earlier, I said that once a Chiari is treated, I tell my patients you don't have a Chiari anymore. I have zero restrictions for them, literally zero, including going back and playing contact football, even if it's NFL. We're talking about the untreated, asymptomatic Chiari patient. Would you let that patient, who still has a significant Chiari, but they're asymptomatic, play contact football?
Then I'll retract that, since there's probably lawyers in the room. If the patient's untreated and they're tight, of course not. But I think if they've been treated, I was under the impression that Jerry cured that kid, then I would be okay and let that kid go back to football.
Sustained, Bob, sustained.
So pre and post, yeah, and I think that's. But there are, I mean, to your point, I think there are some surgeons that would say go play football, and you know. You're asymptomatic, but yeah, so I think we're kind of unanimous on that.
Yeah, just a quick thing. When I was in the Air Force, it was really interesting.
That's Jerry, by the way.
They asked me, the guidelines were not very clear on this, you know, but there was an F-16 pilot that had a very tight Chiari. And they asked me, oh, what's his risk of injecting out of the aircraft? I'm like, I have no idea. You know, and this is one of these Top Gun pilots, and you're instructor level. I mean, what are you going to tell this guy? Your career's over, you know? And it was a very difficult decision. But they're mostly, unfortunately, they found out, well, I'll be on videotape. I got to be careful. But they're worried about the plane in a big way as well. So it's something that we don't know the answers here. We don't really know the true risk of that football player, but there are clear tier A sports that we worry about: football, rugby, ice hockey, boxing. I mean, they are at a very high level. But lacrosse, soccer, are they any different? We don't really know the answer, but it's sort of common sense of what's the player like? Are they really going to play for high level? This kid clearly was. He's now a scholarship. He's a senior in college at Division I school. I mean, he was going to play. And, you know, the family's dependent on that kid playing. This was his lifeblood. So it's very hard for us to take that away from him. But surgery helped to get him back to play. He became symptomatic, so it was an easier decision to swallow. But if he was truly asymptomatic, do you really going to operate on him just to get him to play football? That's where it gets tricky, I think, ethically. Like, do you really want to do that?
Yeah, and to your point, it's not, it literally is these people, it's their life.
Yeah.
I mean, they equate this with their life as opposed to somebody who's playing football just to make the varsity team is never going to play again. Yeah. Questions from the audience?
Dr. Iskandar, thank you so much for this study and the tremendous amount of work I'm sure it entailed. A question about the outcome measure, looking at the syrinx size. If you can describe more details about, how you did that, and also, I don't know if I missed that. Are you also looking at the symptomatology? Obviously, that's hard to do, but at the end of the day, you want the symptoms to improve. So, and not just the syrinx size. And are you checking that?
Yeah, sure, Brent. So there was a primary endpoint, which was the syrinx, a secondary endpoint, which was clinical. So we did look at clinical improvement as a secondary endpoint. So I don't know if you're asking me about the details of how we measured syrinxes, but it's basically look at the cross-sectional diameter and whether there's been a 50% decrease in the size of the syrinx. That was our primary endpoint.
Yeah, one other thing was there was a lot more females in one of the groups, I think twice as many, and I think this is pediatrics, so maybe there's not as many questions about that, but that was another noticeable difference.
What are you trying to say?
Well, maybe among the adults, there's a lot of new data talking about kind of different symptomatology and even morphometry, and so that could be one factor, maybe making these group differences not be apparent if there was some.
I mean, that's the issue with any small study. A pilot study is there to come up with potentially major differences and study them further. So it's a good point.
Any other questions for? One question back here.
Thank you. Hi, my question is for Dr. Grant. You made mention that the fatty film of the low or normal conus position is still controversial. Did I understand that correctly? And if I did, can you extend on that a little bit?
Yeah, there's less controversy that the spinal cord is low, which you can identify usually L3 or below, maybe below the mid portion of L2, that is something we're worried about, with or without a fatty phylum. It's when the spinal cord looks completely normal, maybe L1, and there's some fat in the phylum. What do you do with those? And I think we've polled our neurosurgeons around the country, with different groups, and it's not a clear answer there. Some actually cut the fatty phylums when the spinal cord looks normal without symptoms, in a baby. Others kind of wait if there's symptoms, but it's not that simple because sometimes there's a lot of fat in the phylum. It's a big, thick fat, and sometimes there's a streak of fat. I leave those alone personally, but the controversy is really with a normal conus position appearance, not clearly a tethered cord, but fat in the phylum. Do you cut those? Because you think that they're in some way tethered in this occult way that we can't see. But do you cut those, Benny?
No, so there are a couple, this is a complicated answer. So 6% of the normal population have fat in their phylum. So 6% of normal, you can't be cutting phylums on 6% of the population. Tim George did a study years ago that looked at the histology. He took phyla and cut them and looked under the microscope and found that in the normal patients who were not tethered, the fat was more distal in the phylum, whereas the tethered patients, it was more proximal. Usually we worry about fatty phylums when the phylum is very thick, like Jerry said. Those we worry about because that's really pathological. Phylum shouldn't be that thick. That said, even the criteria of low conus and fatty phylum has not really been established on any scientific data. We do it routinely because it's a low-risk surgery and because 50 years ago, the natural history studies seem to suggest that maybe that's a good thing to do. But there's really no data on that either. So we're taking it even to a higher controversial level by saying, okay, well, what if the conus is normal now? It's a tough question.
Thank you.
Any other questions? So also you can write questions at any time. If you think of something at lunch or whatever, write it and hand it off, and we'll bring it up here anonymously, and we'll ask the appropriate people or the group in the panel. So, the more discussion, the better.